Good morning, everybody. Welcome to this MS Views and News Wellness Summit. All right, it's the first of its kind that we're doing in the Atlanta area. The company that sponsored today's event for the in-person aspect, and for most of it, obviously online as well, is SANDOZ Pharmaceuticals. Other than SANDOZ being our exhibitor as our primary sponsor, though, we have exhibit sponsors. We have Alexion, Banner, Life Sciences, Genentech, Horizon, Novartis, SANDOZ again, and TG Therapeutics. And we should give them all a round of applause for everything that they did, right? Okay, fabulous. Thank you. All right, who doesn't know about multiple sclerosis? Funny question, right? But do you know how it began? Do you know how you got it? All right, well, that's our next speaker's role in what he's here today for. And I'm sure you know Ben Thrower, medical doctor, neurologist from the Shepherd Center. Well, he's a medical director of the Andrew C. Carlos MS Institute at the Shepherd Center. And he is here today to speak with you about MS101, the basics. So let's welcome Dr. Thrower.
Good morning, everybody. Thank you for being here. Thank you, Stuart and your crew. You guys are amazing. Thank you for putting this together, and thank you to the sponsors for making this possible. And thank you to all of you in the MS community for coming out today in person and expanding your knowledge base. We really appreciate you being here. Some of you out there I know very well, and I know you are MS experts. You've been living with MS for a while. Some of you may be newer to MS, and so what we wanted to do is kind of set a level playing field, talk about just MS 101. We're going to go over some basics of MS. Some of these things you folks could probably be up here teaching as well, but it's good to just get a little refresher course, and we will talk about some new things that are out there as well. So, big picture, how should your central nervous system work? A lot of you have probably heard that our brain and spinal cord are basically a big electrical system, and the nerve fibers or axons, which we have pictured here, it's like an electrical wire, and the insulation of that wire is the myelin. Myelin is mainly made up of fat. If you look at it in real life, in a brain section, it looks shiny. It's mostly fat. It's about 95% fat. It's a really good sort of insulator and sort of keeps the electrical current going where it should go. The yellow gaps in between the blue are called nodes of Ranvier. These are gaps in the myelin, and the electrical information that's going to and from the rest of your body is going to jump from gap to gap to gap. Really fast, really efficient way of getting information to and from your body. Now MS is going to come along and kind of throw a wrench into that system. So MS is a demyelinating condition. It's going to chew up that myelin. But in 1998, Bruce Trapp at Cleveland Clinic shows us that it actually does more than that. It actually cuts the wire. And so that's called axonal transection. So you can conduct an electrical current across a demyelinated nerve fiber. It's not as efficient as it used to be, but it does work. But this doesn't work. If you cut the nerve fibers, you're done with any electrical conduction. So just kind of MS at a glance, we think there are about 1 million individuals in the United States with MS, probably more, but this is the most up-to-date number, which is a far more realistic number than the 400,000 we used to use from like 1970 through just a few years ago. The second bullet, this is new information. So if we were having this discussion up until a year or two ago, we said that MS was more common in people of Northern European descent. So if you asked us to describe a prototypical person with MS, we would have said it's going to be a 30-year-old white female. She's probably blonde, blue-eyed. That's not true anymore. So now, for the first time ever, Black women are the number one newly diagnosed individuals in the United States. What does that represent? Is it that we just did a really poor job of diagnosing MS in the Black community, or are the demographics actually changing? I don't think we have the answer to that, or is it a combination of both? It is autoimmune, so it is its relatives are things like rheumatoid arthritis, lupus, psoriasis, Crohn's disease. These are all conditions where your immune system is picking on something in your body that it should not be picking on. There is a misperception that people with MS have an underactive immune system. The only reason your immune system would be underactive or you would be immunocompromised would be if we do it with the medications. In its natural state, MS is a relatively overactive immune system in a very specific way. It's picking on something in your body, the myelin and the axons, that it shouldn't be picking on. It does result from this interesting sort of combination of genetics. So MS has a genetic component, but it's a weakly hereditary disease. So if you have MS, the likelihood that your first-degree relatives, your children, your brothers, your sisters, the likelihood that they're going to have MS is probably about 3%. There's a 97% chance that they're not going to be affected by MS. There are environmental influences, low vitamin D levels early in life, exposure to common viruses, with a lot of research recently focusing on Epstein-Barr virus. To the best of our knowledge, MS does not represent an ongoing Epstein-Barr virus infection. It represents Epstein-Barr virus having fooled your immune system into attacking the myelin and axons at some point in your life. If we did antibody testing, IgG testing for Epstein-Barr virus on everybody in this room, probably everybody in this room has antibodies to Epstein-Barr virus. Most of us have been exposed. But only a small percentage of people actually had mono. And so it looks like the Epstein-Barr virus story is sort of a virus hitting your system at just the right time in someone who's genetically susceptible. And that can potentially push you down the MS pathway. So we've always in the past talked about 4 types of MS, and we still do, but we've changed the categories a little bit. So 85% of people will present with relapsing remitting multiple sclerosis. Over time, there is a tendency to sort of migrate towards secondary progressive MS. When you come in with your very first attack, whether it's optic neuritis or transverse myelitis, we call that a clinically isolated syndrome. Some people with a clinically isolated syndrome will truly only have one attack in their life. For other people, it's really their first manifestation of multiple sclerosis. We've dropped one of the categories you used to see on old slides or presentations called progressive relapsing MS. You won't see that term anymore. Primary progressive MS represents probably about 10% of the MS community. It doesn't play by some of the same rules. It's actually more common in men versus women and actually starts a little bit later in life. We've actually subdivided now secondary progressive MS. So now we divide secondary progressive MS into with activity and without activity. And when we say with activity, we mean that you're either having ongoing relapses or new lesions on MRI or enlarging lesions on MRI. If you say that someone has secondary progressive MS without activity, we mean you don't have relapses, you don't have new lesions on MRI. I would argue that secondary progressive MS without activity is kind of the classic way we usually thought of MS. When you look at disease-modifying therapies for multiple sclerosis, what you'll see with a lot of them is that they are FDA approved for relapsing forms of MS. So when we say relapsing forms of MS, that's a short way of saying someone could have a clinically isolated syndrome with a high risk for future events. They've got relapsing remitting MS, or they've got active secondary progressive MS. All of those fall under that relapsing category with MS. One of the things I think healthcare providers and your team at a comprehensive MS center want to do is to try to find a way to make MS, number one, boring for you. We want MS to just be as small a part of your life as possible. Ideally, when I'm working with a newly diagnosed individual, I'd like to know what their life plans are, and we would like to try to do everything we can to let them keep those plans. And I will say that I plagiarized this from a lady named Wendy Booker. She's a woman living with MS who's pretty inspiring. She's done the 7 summits. She's climbed the highest summit on every continent with MS. And so she talks about the car and driver model. And what this speaks to is, where does MS fit in your life? So your life is the car, you're the driver. So for some people, when they're diagnosed with MS, they just say, I'm not dealing with it. I don't have it. I don't want to hear you. I'm putting my fingers in my ears and saying la, la, la. So they're sticking their head in the sand. So this is saying I'm just kicking MS out of my car. It's not part of my life. This is denial. And it may be a normal phase to go through when you're newly diagnosed, but we don't want you to stay here for very long, because if you're ignoring your MS, you're not dealing with your MS. And so we don't want you to have this car and driver model. The other car and driver model is that MS is sitting in your front seat, it's in your ear, and it's talking to you, it's trying to grab the wheel, so you cannot ignore it. If you're in the midst of a relapse or you're dealing with significant symptomatic issues, MS may be really right in the front seat with you. Again, a place to be, but we hope that people don't live here most of the time. We really don't want MS to be driving your car. And so again, if you're newly diagnosed or you're dealing with a big bad relapse or a big symptomatic issue, maybe the MS is driving the car for a while, but we want you to take the wheel back. And we would like you to get to this place. We would like for you to put MS in the trunk of your car. You're dealing with it, but it's not driving the car, it's not in your ear all the time, and you are acknowledging it, but we want it to be as small a part as possible. So that's where we want you to get to. So I picked two individuals that I find inspirational, one that lived with MS, one who didn't. So Can Do MS Center played a big role in my professional career in kind of forming how I think about MS, how I realized that wellness and exercise are a big part of managing your MS. And so before Can Do MS was called Can Do MS, it was called the Jimmy Huga Center. Jimmy Huga's mantra was, don't focus on what you can't do, focus on what you can do. Jimmy was one of the youngest Americans ever on the U.S. Olympic ski team and downhill racing. The year that he was in the Olympics, the U.S. men up until that point had never won a medal in any skiing event in the Olympics. Jimmy was 17 years old. He had already had his first MS attack at that time. He just didn't know it. Won the bronze in the downhill and then was diagnosed with MS shortly thereafter. Great individual. So I'm at Shepherd Center. So James Shepherd has been someone that's near and dear to my heart. And James Shepherd's one of his mantras for Shepherd Center is we were the bridge between I can't and I can. So that is one of the things we really want people living with any long-term health issue to focus on, is try to take sort of a survey of what are your strengths, your assets, what can you do. Let's try to help you with the can'ts, but let's live more in the can and not the can'ts. How you think about your health is incredibly important. And this was a study I pulled that looked at people dealing with heart disease. And they looked at two groups of individuals. They looked at people who had a very negative outlook on life. These were your Eeyores. And then they looked at people who had a very positive outlook on life. These were your Tiggers. The Tiggers had about a 25% lower rate of heart disease a third lower rate of heart disease over 25 years when they looked at them. So how you think about your health really is very important. That's not that we want you to minimize your MS. MS is not fun a lot of the times, and we know that it can be a struggle, but we want to try to give you the tools to push past that struggle. One of the tools that we want you to be aware of is the people around you. So when you're having a rough time, take advantage of your support networks, whether it's your significant other, your other family members, your friends, pets. For a lot of people, our pets are a huge support system. Work, places of worship, things that you have control over. So these are your safe harbors when MS is giving you a hard time. So everything that we do in multiple sclerosis, it doesn't matter if you're a neurologist, a physical therapist, a case manager, everything we do for right now fits into one of these three treatment boxes. We're either treating relapses, we're managing symptoms, or we're changing the course of the disease. We hope that there's a fourth arrow to this diagram at some point in the near future, and that's actually reversing disability. And we'll touch on that at when we finish up. So we could spend hours on any of these, and just again wanted to kind of give you a high-level view. So when you think about how your healthcare team helps you with those three boxes, what you want to look for in your healthcare team is a team that's both comprehensive and integrated. Comprehensive means that you have all the pieces of the puzzle. You've got physical therapy, occupational therapy, psychological support, whatever you need to help you manage your MS. And integrated means that those pieces of the puzzle are talking to one another. It's interesting. And I know my fellow speakers here have seen this. That there are examples of systems, MS centers out there that have all the pieces of the puzzle to do a really good job. They're comprehensive, but the pieces of the puzzle aren't speaking to one another. We see that sometimes in universities where every department is kind of protecting their turf and they don't want to talk to the other departments or share information. So you would like a system that's both comprehensive and integrated so that you can have the best MS care possible. When we think about managing symptoms in MS, again, we could spend hours on any of these symptoms, but some of the more common things that people struggle with MS are things like fatigue, things like walking issues, cognitive issues. And so I just picked one of these that's kind of one of my favorite things to talk about, and that's gait dysfunction. When you think about going through that list of all those myriad of symptoms, what really helps you and helps us is that if you will try to prioritize, when you come in, if you have a written list of the symptoms that are giving you a hard time, make sure that you put your most important thing at the top of that list. It's interesting. We'll spend 30 minutes with an individual sometimes and talk about different things that they're challenged with and struggling with. And the most important thing to them for that day, they put it at the bottom of the list. It's like, no, let's put that at the top so that we make sure that we address that. Having a list helps your healthcare provider too, because sometimes things that you may think of as individual symptom struggles to us may be interrelated, or our therapy that we're going to look at may cover more than one symptom. So it's helpful sometimes to see that list. Beware of polypharmacy. Polypharmacy, you think it's a nice young lady, no, it's taking too many medications. It means we've turned you into a walking drugstore, and that's not good. So I was taught in medical school that if you're on two medications, we can probably predict what the drug-drug interactions are going to be, or how one drug affects the metabolism of another drug. After two drugs, if you're on 3, 4, 5, 6 medications, it's largely unpredictable. And so just because we have a medication for a given symptom that you're dealing with doesn't mean we necessarily have to use it. I always want people that I work with to know what's available to them, but then you can help me prioritize, should we use a medication, or is there a non-medication way of managing the symptom? We would love to manage your symptoms with things that don't involve just writing a prescription. So this is one of my favorite things to talk about, and that's foot drop. So ankle dorsiflexor weakness, I think that it's potentially under-recognized, and it really has a big impact on people's daily activities. So if you had to pick the two weakest muscles in the legs in a person with MS, it's going to be their hip flexors, the ability to do that, and their ankle dorsiflexors, your ability to get your toes up off the ground. If your hip flexors were strong, and it was only your foot that was weak, you would do something called a steppage gait. When your foot was trying to drag, you would just bring your knee up higher so that your toes don't drag. The problem for a person with MS is that if their foot is weak, their hip is probably weak, and they can't do that steppage gait. So what they end up doing is circumducting. They swing their leg out and around to walk. God did not design you to walk that way. You were designed to go this way, not that way. And when you start circumducting like that, you're using muscles to walk that you weren't designed to use. You're going to fatigue really quickly. You're going to stress your knee, your hip, your lower back. It's just not a normal way of walking. Traditionally, if we send you to a physical therapist, they're going to probably have a discussion about an ankle-foot orthotic. This is a traditional ankle-foot orthotic. They work great for some people. Some people don't care for them. They may not fit in the shoes you want them to fit in. Some people may not like the visibility of it. There are some lighter weight versions out there, toe-off devices. And then there are some over-the-counter devices. If you just have a little bit of foot drop, maybe it's only when you walk a long distance, something like this, the Dorsey strap, which you can buy online, it's about $40. It may give you just enough lift in your foot to give you the improvement in strength that you're looking for. This is a notch up. This is also an over-the-counter device called the Sabo device. Our physical therapist at Shepherd love these. These things are indestructible. It runs about $150. It will last you a lifetime. It's got a little knob you can see on the front there where you can dial up those steel cables to be tighter or looser depending upon how much weakness you're dealing with. And there's some other companies out there that make different versions of these things. And then we get into the high-tech stuff. So we have various electrical devices that may basically rewire your leg. If we can't get the signal from brain to spinal cord to your muscles in your leg to let you raise your foot up, what if we could just stimulate the nerve at the source? And so one of these devices is called WalkAid. The other is Bioness. Our therapists, I would say at Shepherd, we use a lot more of the Bioness device. It's this is the kind of generation 3.0, if you will. If any of you remember, the original device had a little clip that went on your shoe. That was a radiotelemetry device that sent the signal up to the stimulator at your knee. That's gone now, so everything is self-contained at the knee. There is an upper cuff that can be added to hit your your knee flexors, if those are giving you a problem. And then this is brand new. So this just got FDA approval late last year from a company in San Francisco called Psionics. It's called the Neural Sleeve. This is another device for foot drop. It looks like it's potentially going to be a little easier to put on. It's about a third of the cost of the Bioness and WalkAid devices. I will say our physical therapists have really not had a chance to get our hands on this and try it out. What we like to do and what we would like for you to be able to do is, if you're thinking about one of these, we want you to be able to try it, and with working with a physical therapist to see if it actually does what you want it to do before we start fighting with your insurance company to cover it or looking for grants to cover it. So this is just an example in the real world with an individual we work with. Basically, when the picture on the left, she's walking without the Bioness device on, and to go 10 meters, it took her almost a minute and a half. With the device on, she cut that time in half. So she's walking twice as fast. She's still using her walker. She's got some balance issues, but she's walking a lot more quickly. Made a huge difference in her quality of life. So shifting to altering the course with MS, this is your toolbox as of this morning. These are all of the FDA-approved therapies. One of the questions earlier is which of the MS medications that we use are considered to be biologics? Any MS medication that ends in MAB, that's the generic name, these are monoclonal antibodies. So all of the monoclonal antibodies, your MAB drugs on this list, so all of your B-cell therapies, natalizumab, Tysabri, we've got the pending biosimilar for natalizumab, alemtuzumab. So these are engineered antibodies. They are produced by a living cell, so those would all be considered biologic agents. When they go off patent and there's a competing version of it, that's what the biosimilar is. So right now with biosimilars, we do use a drug called Rituxan off-label. It's a B-cell therapy. We use Rituxan off-label in multiple sclerosis. There are two biosimilar versions. There's Ruxience and Truxima. If any of you have Kaiser insurance, they like the biosimilars with Rituxan, so you may be on one of those medications. But so again, we could spend quite a bit of time on any one of these classes of drugs. I will mention just on the right-hand side of the list, the BTK inhibitors. This is a new class of drugs that are right around the corner. These are going to be B-cell therapies, but they work very differently than the monoclonal antibodies that we currently have as B-cell therapies. These are going to be oral medications. They may be once a day or twice a day medications. And I think this summer we will see one of the first phase 3 studies wrap up, and we'll have a bunch of data on one of these BTK inhibitors. So what are we trying to do with your disease-modifying therapy? Well, first off, we want you to tolerate it. We don't want you to have a bunch of side effects from it. We want it to be relatively convenient for you. But then what we would like to see is no relapses, no progression of disability, no new MRI lesions. Those three things put together, you'll sometimes in MS literature see an acronym called NEDA, N-E-D-A, no evidence of disease activity. By NEDA, we mean no relapse, no progression of disability, no new MRI lesions. We always tell folks, we want you to get an A on your MS exam. And so an A on your MS exam is that. If you're on a disease-modifying therapy and you have no relapse, no progression of disability, no new MRI lesions, that's what we're pretty happy about. What do we not see on that list? What we don't see is symptom improvement. It's such a vital thing to talk about. So normally when you take a medication, whether it's a pain reliever, a blood pressure medicine, you expect something to get better, your blood pressure, your pain levels. We don't necessarily expect you to get better with these medications. We expect you to stay the same. If we can keep you the same in the setting of a potentially progressive health problem like MS, that's a success. And then what we need to do is just let technology catch up to you and give you that repair strategy in the future. So when you're selecting your medication with your healthcare team, it's always a kind of a balance between how effective the drug is and how safe it is. Every one of us in this room has a risk tolerance. And so what you and your healthcare team need to figure out is what is your risk tolerance? What's important to you? We have individuals who come in and say, I want the most effective thing you've got, and I'm willing to put up with some risk. Other people say, I want the safest thing you've got, and I'm not willing to put up with a lot of risk. There's no right or wrong in that. It's just a matter of what makes you tick and what's most comfortable for you. One size does not fit all with these medications. It's good to talk amongst ourselves when we have a health problem, go to support groups, be online, but also be aware that just because a drug works great in this person doesn't mean it's the best drug for you. So when you talk to someone and they say, I had a horrible experience with drug X, or I had the greatest experience ever with drug Y, that's their unique experience. Learn from it, but don't necessarily think that that's going to be your experience. Just because something's brand new doesn't necessarily mean it's always better for you individually. We have drugs that have been around since 1993. When we think about a drug like beta-seron, we have people who are still on beta-seron. If you are meeting those goals, you have no relapse, no progression of disability, no new MRI lesions, and you're happy with the drug, just because new things come out doesn't necessarily mean that you've got to switch to it. So how do you choose? It's really a partnership between you and your healthcare team. So you sit down and talk about what things are important to you. Again, there's no one size that fits all with these medications. So things there are other considerations in how we choose a drug that we wish were not is the first bullet there, and that's your insurance company may have a say in this. So something called step edits. Step edits are something the insurance companies do where they say, so maybe your healthcare team wants you on drug C, but your insurance company says you have to try drug A and B before you can try drug C. Maybe A and B are not very appealing to you or to your healthcare team, but because of those step edits, we may have to jump through some of those hoops before we can get to the medication that we would really prefer to use. There are legislative moves around the country to try to keep these step edits to a minimum. When we think about competing paradigms, so how your healthcare team looks at choosing a medication, it's good to kind of know what their thoughts are. So there are two competing paradigms. One group says, I'm going to pick the most effective therapy from day one. The other group says, I'm going to pick the safest therapy, and then if you break through, I will escalate you. So that first paradigm, most effective from day one, is called induction therapy. Going with the kind of the safest drug first is called escalation therapy. I would argue most MS centers in the US are probably more biased towards the induction therapy, going with more effective first. So what happens if you're not meeting all of those goals? So you're getting worse. What could that look like? Maybe you're having relapses. Maybe you're having new lesions on MRI. So again, our goal is perfection with the therapy. If we're not getting perfection, if you're having relapses or a new lesion, then the question is going to be, is that medicine really the best for you, and do we need to look at making a change? I think the more challenging situation, one that we see every day, is I'm progressing, but I'm not having relapses and I don't have new lesions on MRI. I think it's very frustrating for people with MS when we're in the exam room and we tell them, your MRI is stable and you've not had a relapse, and the person says, but I don't feel very stable, I'm getting worse. We believe you, we hear you, we know this happens. It's an area of a lot of research in MS. How can that happen? So when we think about progression without relapses, so you have a stable MRI, you're not having relapses, but you still feel like you're physically getting worse, we have to acknowledge that deconditioning could be part of that equation. Very few people in the United States gets the amount of exercise that we're supposed to get. We could all probably do a little bit better, and people with MS tend to decondition more quickly than people without MS. So normal human aging, it's just a fact that, my brain still says that I can run as fast as my 25-year-old son. My body says otherwise. It doesn't happen. And then that's something we'll talk a little bit about is loss of neural reserve. So when we think about the deconditioning piece, so when you think of functional disability, limitations on what you can do, whether it's walking, your endurance, whatever, what really makes up that sort of loss of function? It's really two things. It's the actual damage in the central nervous system from your MS, and it may be physical deconditioning. So think of disability really as a load that you're carrying. So in the two ends of that load are the actual damage in your brain and spinal cord, and the deconditioning piece. We know that we can do something about that deconditioning piece. If we get people into a regular exercise program, we tend to make them function better. And so what we don't know in a given individual, when you think about that load that you're carrying, how much is deconditioning and how much is the hardwired damage, we don't know, and we won't know how much benefit you can get from physical therapy, occupational therapy, wellness programs until we get in and really start having you work with that team. So neural reserve is an important concept. So neural reserve is how much can I injure my brain or spinal cord and get away with it? So if I have a concussion, how well do I recover from it? If I've had a stroke, if I have MS lesions, and all of us start losing neural reserve as we age, and we probably start losing neural reserve at about age 30. A little bit humbling to think about. If I look at a 40-year-old healthy individual's brain MRI, and then I look at a 10-year-old's healthy brain MRI, they look different. The 10-year-old, because I'm an adult neurologist, the 10-year-old's brain looks a little bit swollen to me. It's not. It's just there's no atrophy. We all get a little bit of atrophy with age. It's just part of being human. So when we think about old MS lesions, one of the analogies that I use is the lake model. And there are a lot of different versions of this out there. My wife and I have a cabin up on Lake Lanier, so I orient to water. So think of your MS as tree stumps in a lake. Some of those tree stumps are above the level of the lake. You can see them, and some of them are underwater. You can't see them. Well, we can see them on MRI, or if we put a swim mask on and went underwater, we'd see them. That's like an MRI. Only the ones that are above the surface of the water are the ones that are giving you symptoms. The lake level is your neural reserve. And as we age, your lake level drops. And so as that lake level is dropping, some of those tree stumps that were under the surface of the water are now above the surface of the water. The tree stump didn't change. Your MS lesion didn't change. What changed is your neural reserve. Some of those tree stumps that were just a little bit above the surface of the water are now a foot out of the surface of the water because the lake level dropped. So when we see an individual with MS in the exam room and they have some progression of symptoms and they're on a really effective therapy, they're having no relapses, they're having no new lesions on MRI, we know that the deconditioning piece is something we can go after. This neural reserve piece, does it make sense to move that person to a different MS therapy? Maybe not. If the MS really is not what's changing, if it's the loss of neural reserve that's changing, I don't know that putting someone on a different MS therapy in that setting is going to change that equation. We're certainly open to having the discussion, but I think this neural reserve concept is really behind a lot of what we see in the exam room every day. So ways of what we know we would like to do is we would like to either keep water in your lake or raise the water level or get rid of the tree stumps in your lake. So this is the whole concept of neural repair. So this is in research. We'll talk about a couple of things. Neuroplasticity is a kind of a different concept from neural repair. Plasticity says if I can't fix the damage, what if I just reroute around it and form new pathways? And then building reserve. We know that we can potentially build reserve through exercise, both physical and cognitive. Challenging your brain cognitively may help build that reserve back up. So this is a study we're doing at Shepherd. So Shepherd Center is one of 3 sites in the United States working with a company called MSTEM with mesenchymal stem cells to try to promote repair. This is just one of many studies out there. There are a lot of different centers. Cleveland Clinic's doing a lot with mesenchymal stem cells. So mesenchymal stem cells are cells that are not from your body. They are usually cells from fertilized embryos from couples undergoing in vitro fertilization. And these are embryos that would have been destroyed otherwise. And so this study is a phase 1. It is early. I believe as of today, there are 9 individuals that have received these cells, 6 of them at Shepherd Center. And so far, so good. So hopefully we're going to see more of that. This is brand new. This is available right now. So this got FDA approval last year. This is from a company called Helios, and this speaks to sort of neuroplasticity. If I can't repair it, what if I could reroute around it? So the PONS neural stimulator, you can see the lady has, it looks like a headset around her neck, and then this little electric wire that comes up, and there's a tab that goes under the tongue. This is the neural stimulator. What they showed in studies with the PONS neural stimulator is that if I took one group of people with MS and had them do aggressive rehabilitation without the stimulator, they got some benefit in terms of their walking. I take another group of people with MS and I have them do aggressive rehabilitation while wearing this device, their walking was better. So we think that we may be promoting new pathways. In the studies, they selected walking primarily. Could it help with other things? Cognition, vision, upper extremity, we don't know, but that is the hope. The challenge with this device is it is aggressive rehabilitation. So it is 3 times a week physical therapy for 3 months. It's a lot of physical therapy. So we have right now at Shepherd 4 individuals who are either in or have completed this program. And with that, I'm going to stop and we'll turn it over to Q&A. This is my safe harbor. So this is a farm that my wife and I are building up in Athens, Georgia. Someday when we retire, we will have animals up there, and there'll probably be a reality TV show about all the things we mess up with the animals. So yeah, if you hear cows crying for help, that'll be us. Yeah.
That's great. Thank you. Let's thank Dr. Thrower. So when you get that farm open up and you're all retired up there, you'll be inviting everybody here
Absolutely.
For a party, right? That's
Absolutely.
That's what I thought. Is muscle tightness decreased somewhat by Roback's muscle relaxants a sign of plasticity?
So spasticity or muscle tightness is common with MS. Your muscle tone is going to tend to be on the high side. Extensor tone in the legs, flexor tone in the arms. Robaxin is more of a skeletal muscle relaxant. We tend to think of it more for back pain, but I've seen people with MS respond to it. Normally, we're thinking more of things like baclofen and tizanidine for typical spasticity in MS, but we do see people get benefit from Robaxin.
You talked about repair strategies that they would come eventually. Can you give us an example? What exactly you're talking about?
Yeah, so the National MS Society has been probably one of the largest funders of research in MS, and gosh, it's probably been 15 years ago. They made the decision that a third of their money was going to go towards neural repair and research. So we know that we have a lot of tools in the toolbox right now to stop MS progression. but we don't have anything yet to reverse it. And so that goal of neural repair really is something we want in MS. It's the goal in spinal cord injury, stroke, brain injury. So I would say the mesenchymal stem cells are just one way that's being looked at. There's research going on at other MS centers where they're looking at repurposing known FDA-approved molecules. So a lot of times you have a drug that's approved for one health condition, but it may have totally different effects, things that we didn't know about. So there are groups out there that are looking at repurposing existing molecules, things like clemastine and metformin that might be beneficial in MS. The cool thing about that research approach is if it works in the lab and then in a small human study, that research is going to move very quickly. And we could potentially use those things off-label while we're waiting for more research to occur because it's already FDA approved for something and we know the safety of it. Yeah.
Okay, thank you. Next question's here.
Okay, you talked about MS being demyelinating disease, but you also talked too about it could actually cut the axon. So should a remyelination therapy come along, if the axon is cut, would that have any effect?
That is an amazingly good question. So that is a challenge. So you're right. If we have just a nerve fiber that's demyelinated but is still intact, then maybe remyelination works for that one. If the nerve fiber is cut, then putting new myelin down is not the issue. So that is a challenge as we go forward with neural repair. The other challenge that we're looking at is something called gliosis or just scar tissue. So a lot of these old MS lesions, there's all this scar tissue around them. When we look at white spots on MRI, it's really gliosis, scar tissue that we're looking at. One of the areas of focus in repair is what if we just cleaned up the scar tissue? Would that let the body heal naturally? Neuroplasticity would be one way of potentially getting around those cut nerve fibers and forming new pathways. But no, that's an excellent question, and I don't know that we have the complete answer to it.
Do Epstein-Barr medications help MS?
Not that we know of yet. So I would say that it is an area of research. There is a drug trial right now with a primary progressive MS therapy that looks like it also has some antiviral properties specifically against Epstein-Barr virus. Again, if MS really is not an active Epstein-Barr virus infection, if it's the result of an old infection, I don't know that an antiviral for Epstein-Barr is going to be the answer. I do think if we had a vaccine for Epstein-Barr virus, we would probably lower the incidence of multiple sclerosis and probably some other health conditions. But yeah, I don't know that an antiviral is going to be the magic bullet.
So my question to add on to what you just said is, what do you do for all the people that never had Epstein-Barr?
So we don't think Epstein-Barr virus is the only pathway to MS. So there are other viruses. Human herpes virus 6, for instance, causes roseola in kids. That virus has been tagged as one. What happens with viruses is they have amino acid sequences on their surface that look enough like myelin basic protein that it fools the immune system in someone who's genetically susceptible. So Epstein-Barr virus is the big one we talk about, but it's probably not the only one.
Thank you for that. And leading off of that, there are other diseases out there that replicate MS, and people want to know, like, how do you tell the difference between MS and neuromyelitis optica spectrum disorder? So what can you tell us about that?
Yeah, great question. So I'm old enough to remember back in the day when we argued about whether neuromyelitis optica or Devick's disease was just an aggressive form of MS or whether they were really separate diseases. We know now they are separate diseases. They are both autoimmune. They're both demyelinating, but the immunology behind neuromyelitis optica is very different from MS. And it is vitally important that we make that diagnosis accurately. If you don't get neuromyelitis optica diagnosed quickly and you let it simmer, the consequences can be quite severe. Relapses with neuromyelitis optica are much more severe than what we see with MS typically, and they don't recover as well. We now have 3 FDA-approved treatments for neuromyelitis optica. We have a blood test, the aquaporin 4 antibody, that lets us separate those two things out. It is not a perfect blood test, but it does have a fairly high degree of specificity and sensitivity in diagnosing NMO.
Okay, thank you for that. Next question is, are there any exercises or activities that can be done to slow the progression of neuroplasticity as that decreases?
The best exercise program for a person with MS is the one that you'll stick to. So there is no, if you prefer being on a stationary bike, if you prefer walking, swimming, whatever you have access to and you'll stick to, we love for you to work with physical therapists to help design an exercise program that's going to be best for you. I do think that regular exercise helps improve neural reserve and probably helps with plasticity. There was a study that looked at people with a severe MS relapse. Both groups got treated with steroids. One group just got steroids. One group got steroids and physical therapy. The group that had the physical therapy had better outcomes after the relapse, and we think it was due to plasticity.
Good morning, Dr. Thrower.
Good morning.
We talk a lot about foot drop, but what about people that have hyperextension in their knees, for example?
Yeah,
Because-
so when you look at walking issues in MS, so we've got the weakness that we talked about, but we didn't talk a lot about spasticity. And so if you have increased tone, your leg is going to want to be straightened out. And so, and part of that sometimes, it's a kind of a spin-off of it. Some people hyperextend their knee, they lock their knee out, and they may be locking the knee to compensate for weakness in the leg, or they may be doing that due to spasticity. Regardless, it's not great for the joint itself. And so one of the things therapists will sometimes do is put people in a knee cage to try to prevent that hyperextension of the knee. The spasticity part, where the leg wants to stiffen out, is a double-edged sword. Too much of it is bad. A little bit of it may be actually a good thing. Some people use a little bit of increased tone in the leg with extensor tone to actually help compensate for their weakness. So that's where we rely on our physical therapist to help us sort out. I can give you enough baclofen or tizanidine to probably make you looser. I can also make you less functional by doing so, or make you really sleepy, but by pushing too hard. Yeah.
Next question here.
Dr. Thrower, you mentioned, I think, mono possibly earlier in life is a pathway towards MS. Curious about that. Also, for those of us that have been athletes, specifically football, with possibly concussions, is that a potential start to MS down the road?
So mono is one of the ways that Epstein-Barr virus can manifest. So even though most people have been exposed to Epstein-Barr virus, not everyone actually got sick with mono. So it doesn't look like you actually have to have had the mono symptoms for Epstein-Barr virus to fool your immune system. So again, most people have been exposed to Epstein-Barr virus, but only a small percentage get mono. On the head injuries, the official answer is there's no correlation between prior traumas and MS. I would say so before we use the current diagnostic criteria for MS called the McDonald criteria, we use something called Poser criteria. Charlie Poser was MS expert decades. He believed that he had some evidence that trauma might be a little bit of a risk factor, but the official politically correct answer is that there's no correlation.
Why does exercise help with deconditioning?
So deconditioning is just us getting weaker, tighter, more fatigued, not using oxygen as effectively, and that's whether you have MS or not. And we know that whether you have MS or not, if you get exercise, you're going to recondition. So when the physical therapist speaks some today, they'll cover that as well. So we know that people can function better with exercise. I think there are a lot of other potential benefits. People's mood tends to be better when they're exercising. I think depending upon the exercise setting that you're in, if there's a social aspect, like when people use the aquatics program at Shepherd Center, I think there's the physical benefit, but I think a lot of sometimes people just like being around other folks and getting out of the house. Yep.
How would you form the discussion with your healthcare provider to get that neuro sleeve?
So the neural sleeve from Psionics, it would go through a physical therapist. So you need your healthcare team to refer you to a physical therapist. I would probably call the physical therapist and see if they actually have it yet. Again, our therapists are pretty aggressive at Shepherd in getting the newest technologies, and we have not physically gotten one in our hands yet. So I would make sure they actually have it before you go.
Good morning, Dr. Thrower. I just had a question about the Helios Pons therapy. Are there subjects being accepted for that study participation?
So it's actually, so she's asking about the Helios, the PONS neurostimulant. So it is FDA approved, so it's not officially a study. It's just, but it's, so yeah, if outside of Shepherd, I don't know where else they're doing it at, but you could probably go on just Google Helios PONS and see where else they're working with it at. So right now, the way we're working at Shepherd is if we have people that are interested, is we're just sending their name to our lead physical therapist, and she's adding them to the list.
Good morning, Dr. Thrower.
Morning.
I have a question about muscle spasms. You mentioned that you could have your MRIs are good, everything is going fine, but all of a sudden you start having muscle spasms, just like out of the blue. What could cause that, even though everything else is going okay, and you haven't had any relapse in years?
So spasms and spasticity are typically not due to new MS lesions. Usually they're due to old MS lesions. And so spasticity and spasms can evolve over time due to the old lesions. Probably one of the best examples I can give, if you went to Shepherd Center and you looked at the spinal cord injury unit, you looked at someone with an acute spinal cord injury, they won't have any spasticity or spasms for months. When you see them down the line, they're going to deal with spasticity and spasms. They had no new injury. This is all just due to the old injury. I think the same thing happens in MS. I think sometimes there can, just as the lesions evolve, the spasms can develop. If you have spasms that come on out of the blue, kind of take a look at your life and say, is there anything else going on? Am I sleep deprived? Am I stressed? Did I start a new exercise program? We don't want to discourage that, but sometimes if you start a new exercise program, spasms can act up. And then probably most importantly, do I have an underlying infection? Underlying things like urinary tract infections, upper respiratory infections will sometimes kick off spasms and spasticity where you didn't have it before.
I have a question, and this may be completely off the cuff, but is there any correlation between MS and aneurysms?
So no,
None
yep,
whatsoever?
completely unrelated. Yep.
While I make it to the back, to the other side of the room, there's a person asking about the BTK inhibitors. What can you tell us?
So BTK inhibitors, again, are going to be the next kind of class of drugs, totally different from anything we've ever had in multiple sclerosis. So BTK stands for Bruton tyrosine kinase. It's a part of the pathway for how B cells, as part of our immune system, talk to one another and how they make more B cells. So these are oral therapies. They are not biologics. It's a small molecule. They do cross the blood-brain barrier. They go into the B cells and they affect the way B cells, again, communicate with each other. So we need to see, all the studies as they come out, but they are on the way. So there are 3 or 4, depending upon how you look at them right now, that are in the pipeline.
How soon in the pipeline?
So summertime, we should be seeing the big set of data on one of them.
Okay,
Yep.
great. Thank you.
The neural repair therapies are really exciting. While we're waiting on more research to happen there, what are your thoughts on over-the-counter things that purport to do that, like lion's mane mushroom, particularly remyelinates, other potentially even the studies that are happening with psilocybin about increasing neuroplasticity? What are your thoughts on all of those?
It's interesting stuff. I mean, the lion's mane, a lot of the mushrooms that are out there clearly have effects in the immune system. A lot of times we can say in theory why something may look good. There's just not a lot of data yet. So then as a healthcare consumer, what you're left with is what's the evidence, what's the risk, what's the benefit, and is it something I want to try? I'm very open to people trying alternative and complementary therapies. I would hold those therapies to the same standards you do a prescription drug, kind of know where you're getting it, what the quality is, and probably try to only do one variable at a time. If you're going to start something like lion's mane, or you're going to, whatever it is, try to do just one thing at a time, and be sure to let your healthcare providers know that this is added to my medication list. There is a a great book out. So Alan Bowling is an MS physician in Colorado who has written 3 books on alternative and complementary therapies in MS. It's kind of a consumer guide. So if there's data out there on something, he'll put it in the book. That you can find them on Amazon. It's just bowling like the sport. Yeah.
Awesome. Good morning, Dr. Thoreau. Thank you for being here. It was really helpful for me to learn about neuroreserve. I'm curious what exactly that is anatomically, and can you see it on an MRI, the lack of it, or the loss of it?
Good question. So neural reserve is not a part of the brain. It's all, the whole central nervous system, and it's not like it's just one area. It's just how much injury can that person's brain sort of adapt to, or spinal cord adapt to, and probably different people have different levels of neural reserve. We can see someone that has an MS lesion in a certain area and they've adapted to it very well, and other people will have permanent neurological symptoms from it. So it's not a location in the brain, it's just the brain and the spinal cord's overall ability to adapt to those injuries. Yeah.
Okay, before I run around there anymore, let me get some of these online questions. My New Jersey doc said I have to change medications. Then I moved to North Carolina, and my neuro is giving me time to see if I need to change. I know you don't know me or my case, but what criteria is to say someone transitions from relapse remitting to SPMS?
So we know what we want with a disease-modifying therapy. We want that A on your MS exam, no relapse, no progression, no new MRI lesions. If you're not getting that, then that's where that discussion is going to start occurring. There is no absolute black and white algorithm for at what point you need to switch someone's therapy. It is a dance between the healthcare team and the individual living with MS. Other factors include, have I been on multiple therapies? Maybe there are not great other options, or maybe I'm on a therapy where there are tons of other options available. So there's no set algorithm for when you kind of move on to the next therapy. Determining when someone has moved from relapsing remitting to secondary progressive is an incredibly inexact science. Realize that those terms that we use were really used to describe the natural history of MS, or what MS looks like without treatment. Most people with MS are on a treatment. So what if the person is having some progression of symptoms, but if we took them off their therapy, they would have more. They'd actually have relapses and new lesions on MRI. So at face value, they kind of look like secondary progressive MS, but if we took their treatment away, they would look more like relapsing remitting MS. We tend to be, I think, sometimes a little cautious with being very hard-nosed with the labels that we put on people. If we label someone as having secondary progressive MS without activity, what you've just told that person's insurance carrier is that there's no FDA-approved treatment for that, and that maybe that insurance carrier decides to not let the person be on any disease-modifying therapy. So we sometimes will talk around things a little bit in people's medical records, and I would just say it is not an exact science as to when someone's made that transition.
Okay, great. Thank you for that. And going back to NMO, online question is, how would a patient be told that they were mistakenly told that they have MS when they have NMO?
So 41% of people with NMO were mistakenly diagnosed with MS first. So that is a common question that comes up. It's really going to be the healthcare team having the suspicion that your MRIs, your clinical presentation, and your blood test. I think anyone coming in with their initial bout of optic neuritis or transverse myelitis needs to have NMO antibody testing, or the aquaporin 4 antibody testing. That discussion, I bet, occurs in MS centers around the country on a daily basis, where someone says, you know what, knowing what we know now, science evolves, we think that you really have NMO, and we probably need to look at switching you to a more effective therapy.
Yeah, so that's what she's asking. She just wants to know, since her medications don't ever seem to be working, and the doctor's always suggesting she try something else, wants to know if possibly that is something that she should recommend to her doctors.
I would make sure she's had the blood test, the aquaporin 4 antibody.
Okay, great. Thank you. All right, next one says, how do you check a person's neuroreserve?
So there's no way of measuring neural reserve. That's a great question. We wish we had a little meter that we could hold up and say, oh, your neural reserve is almost empty or it's going down. Yeah, there's really no way of measuring neural reserve.
Why would a person with MS have an infection but only have a fever of 100? And how can we have our GP prescribe appropriate medications, flaring MS symptoms at the same time?
So people with MS don't tolerate infections very well, and you definitely don't tolerate an infection if you have a fever to go along with it. So we know that as little as of a half a degree rise in Celsius in your core body temperature can make a huge difference in how your symptoms are acting. With an infection, you have all kinds of things going on in your immune system, inflammatory cytokines that are being released to help fight that bug off, but they may make your MS symptoms act up also. So we have a very low threshold for looking for infections in people with MS, especially urinary tract infections.
Okay, thank you for that. If a person in your practice had SPMS, what would you recommend them for treatment?
So secondary progressive MS, we would want to know, is it with activity, without activity? We would definitely want to be aggressive with rehabilitation. We would talk about the limitations in disease-modifying therapies where we don't technically have anything that's FDA approved for secondary progressive without activity. But we would talk about maybe some where science is at that might say, could we try something off-label?
People want to know, they've heard that you're retiring, and they want to know when that is happening.
So the tentative plan for us to go and put animals up on the farm is October of 2026. I may keep on board for 1 day a week at Shepherd. We'll see. Depends on how bad the drive from Athens is to Buckhead. So that's the plan.
Okay. Well, let's give Dr. Thrower a round of applause. Have a great day, everybody, and drive carefully. Be well. Thank you.